that's fine. Great, fine. I'm just gonna quickly check again if I'm recording it. Yeah, that's fine. That's great. Fine. So, Uro-Oncology multidisciplinary team meeting, renal cell carcinoma. This is just a kind of a sarcastic photograph which was recently shared. So I just thought I'll put it with a nephrectomy going on, right? So first case, right? So I'll start with our residents, right? So this is a lady who was in 2015. She was an 80-year-old lady. She was a stone patient, and one of my colleagues had done PCNL, and I think it was more than one PCNL. So a scan in 2015 has suggested about 2.9 centimeter small renal mass on the right side. Past history, hypertension, performance status was about 1, which means she's reasonably fit and mobile. BMI was low. Kidney functions were normal, right? So a reasonable case. So Dr. Kesar, why don't we start with you, right? So
okay.
The right kidney. So why don't you just tell us, what do you see on this right kidney? Anything abnormal?
Yeah, I see Axial's view of a CT scan showing a mass in the lower pole of the right kidney.
Right. That's it. It's about 3 centimeter. So,
yeah.
So, I mean, obviously, what are the chances you think this could be malignancy?
Yeah, so it depends. If the Horn's view is greater than 10 to 20, then the possibility of malignancy is high.
Okay, right.
So yeah, that's a possibility.
Fine, great. So what are you going to do? You have known the patient already. That's the patient details. What would be your choice?
So she is an 80-year-old female. Though the performance score is good, the the GFR is also not bad. But I will offer active surveillance in this patient because it's a small renal mass, and I don't think there's any need to intervene. Yeah.
Fine. Okay. Right. So, Dr. Abu Sadiq, what are you going to do? What would be your choice? Sadiq, can you hear me?
Zishan.
Yeah.
You hear me?
Yes. Yeah.
So basically, this is an 80-year-old lady with a performance status of 1. So she had minor disturbance of her general activities. It's a small renal mass by definition, is 2.9 centimeters. So as you rightfully said, Dr. Castle, she's probably, she needs to be counseled for several options. So the options start from basically, active surveillance. So that's one of the options.
Yeah.
And then the other option would be intervention. And the intervention could be either minimally invasive treatment, different modalities of treatment, of course. It depends on the availability of the resources in your place. So in our place, for example, we have radio frequency ablation, cryoablation, microwave. And of course, you move on to the surgical options. So ideally, you should lay all the options to the patient and let them choose. But if it was up to me, I would probably prefer to counsel her for active surveillance in the first instance. She is 8 years of age, and that's a small renal mass. And based on the evidence in the literature, those small renal masses, they're very slow to progress. We're talking about less than 1 millimeter per year. And based on the papers in the literature, there's more than actually 20% chance of them could be actually benign. So if you decide to counsel this patient for active surveillance and she agrees, then obviously her case will be discussed at the multidisciplinary team meeting. And ideally, she should have a percutaneous renal biopsy to identify whether it's benign or malignant and identify the grading of it, of course.
We are actually doing the multidisciplinary meeting. So yeah, that's absolutely fine. So yeah, so active surveillance, we will go on. And Professor Lizrak, do you agree with that?
Yes, of course, I agree with that.
That's okay, fine, right? So
yes, and the age and also for the left kidney, it is a small one, or this is just.
I'll come to that. I'll come to that. I'll definitely come to it because I just want to ask a couple of residents first, and then you guys just need to back up the answer. Yeah, so that's fine. So we monitored the mass as I think the consensus is. We continued CT scan 3 years later. We are on. The mass is about 4 centimeter now, right? as you can see, it's slightly more exophatic at this end. Patient is still reasonably fit, right? So Yusuf, why don't you just tell me what are your options now? Dr. Bellarmine, can you hear me?
Yes.
Yeah.
Yes. Hello, everyone.
Options now, please.
Yeah. Actually, I wanted to talk before to say like when it was like 2.9 millimeters, centimeters. Sorry. I would say radio frequency.
Yusuf, can you
Yes.
just answer now? 4 centimeter mass. What are you going to do now?
Yeah. I would go for partial nephrectomy.
You would go for partial nephrectomy, right?
Yeah.
James, what would you
Since
go for?
the other kidney is too small, so maybe it's more risky to leave it there.
Fine. Okay, great. So you would go for partial nephrectomy, right?
Yeah.
Okay. James, Dr. Blackmore, what would you do?
Yeah, certainly I think partial would be reasonable, but I'd probably also potentially, depending on what's available in the center, whether RFA would still be an option,
Okay.
or cryo.
Okay, great, fine. So would anybody consider biopsying this lesion before any intervention finalizing on?
Yes, definitely.
Right. Okay. So you would probably do biopsy irrespective of whatever you, right? Okay. Sadiq, what would be your choice?
So, I mean, both options.
Abu Sadiq, can you hear me? I asked you before as well.
Sorry, Zishan, you're asking whom?
Abu Sadiq.
Can you hear me? Can you hear me now?
Yes, please. Can you answer? What would you do?
Yes, I would want to go ahead with the biopsy,
Okay.
then for active surveillance.
Okay, great.
Because this patient is elderly,
Yeah.
the performance status is good, but there are surgical risks for this patient.
Okay.
And the contralateral kidney is functioning well.
Fine. Okay, great. Fine. So that's.
But if the biopsy shows a high grade malignancy, then I can offer other form of minimally invasive therapy.
Fine. Okay. So that makes. Ali, you wanted to say something, please?
No, basically, Zishan, I agree with the rest. So ideally, if you're going to provide this patient with either active surveillance, which is probably not the case now, the tumor has increased from 3 to 4 centimeters within a short period of time, or if you're going to offer minimal invasive treatment, then these are the two main indications for a biopsy.
Yeah. Okay.
And of course, the other indication is if you have an indeterminate mass, which is probably not the case here.
Okay,
so I feel that if you were going to offer this patient a nephron-sparing surgery, then probably we could avoid the biopsy and go straight for it based on the fact that it has actually grown faster than it has.
Fine. Okay,
if you're going to go for continuing active surveillance, probably not in this case because she has decent performance status. Or if you're going to go for intervention treatment like minimal intervention like RFA, cryo, then a biopsy would be warranted.
Professor Liesrek, I think you were nodding your head, or did I feel that way? What is
yes, of course, I agree with Ali. And if we want to do surgery, there is no need for biopsy.
That's fine. Great. So I think pretty much everybody is agreeing now. So we attempted biopsy and which failed, and you can see the reason that this is her. You can see her her pelvic bone, and the kidney is very low down. It was a tiny lady. They couldn't just really do the biopsy, which means our ablative treatment was out, right? So next option, very quickly, Sami, what would you do, Dr. Hamid?
So looking at the other kidney, if that's a normal kidney, which it looked a bit smaller earlier, then you could counsel the patient for a partial nephrectomy. But also, you know, there is also, she's 83, it's grown 1 centimeter in 3 years. So you could also counsel her for continuing surveillance. But at that point, it wouldn't be active surveillance so much, I would say. Maybe.
Fine, okay, great. So any more information, Kesal, if you come back to that, any more information which might help you, any more imaging which might help you before going in and operating on her, on this patient, considering the left kidney is a concern?
I think a DMS adrenogram would be useful, isn't it?
Okay, that's
because it will give you an idea. Obviously, the left fund isn't doing much, but I think it will give you some sort of prognostic idea about post-operative functional status.
Okay, that's fine. So, and thanks, Nina. Welcome. And Kesal, do you agree with that?
Yeah, the DMSA will give you more of the kidney function. In this case, when the size is less than 4 cm, so we're not worried of lymph node involvement. But an MRI could to show venous thrombus, but in this case, least likely. So I think a CT scan we can go ahead with a CT scan, I think.
Fine. So we did a DMSA, which let's say left-sided function is 40%. So it's slightly reduced compared to right side, but we have, I think, already have a consensus about doing partial nephrectomy. All right, great. So we counseled her for that. And on the day, patient changed the mind to laparoscopic radical nephrectomy because more concerned. And I think what Sami was saying, probably that was on their mind as well, about more complications. And to make matter worse, the pathology came back as oncocytoma, right? So I think biopsy, whoever was going for biopsy, even before partial nephrectomy, I think that probably could have been the right approach considering the age of the patient. So post-op EGFR was 31, but in a couple of years' time, last EGFR, the other kidney has picked up nicely, is 51, right? So yeah, that's about it. So it was a pretty standard, straightforward case to start.
Nishan, can I make a comment, please?
Please do.
Just from the resident point of view, I did not hear anyone suggesting to complete the staging through CT chest. Did we do complete staging? Did any of the resident or trainees mention about doing a CT chest?
Yeah, I mean, I think I should have clarified. There's no metastatic disease here.
Thank you. I think from our point of view, it should be clearly documented that it's organ confined disease. Thank you.
That's fine. That's great. Yeah, no, thanks for reminding. So we'll just move on. Case 2.
Just before we move on, Zishan, I mean, obviously this webinar is meant to be educational. Yeah. So for the junior colleagues' point of view, so as I said, the biopsy is indicated for active surveillance for indeterminate mass or consideration of minimal invasive treatment. Biopsy is probably not indicated in a simple, straightforward case for partial or radical nephrectomy. Now, this lady had a 60% function of that good kidney, and I can tell that maybe she has made an informed decision to go for laparoscopic radical nephrectomy. Now, I'm just extrapolating from Professor, from his previous lecture. So what's minimally invasive in this patient would have been an open partial as opposed to a laparoscopic radical nephrectomy. I think that would be a good learning point for this. It's a small renal tumor, and she would probably have been better served with an open partial if the facilities are not available for lab partial or robotic partial.
Yeah. So yeah, that's what the plan was. But I think she probably overthink between clinic and have theater operating day, and on the morning they just came in with the change their mind. Yeah. So yeah, initial counseling was for partial nephrectomy. Great. So thanks, Ali. So case 2. October 2017, this patient presented, 63 years of age, initial imaging done for hemochromatosis. CT scan picked up about 5 centimeter right-sided renal mass. Past history was unremarkable, good performance status, normal EGFR, right? I'm just gonna show you the picture here. And Yusuf, why don't you just tell me what do you see in the picture? Dr. Balamai?
Yes. Actually, I see a large tumor in the right kidney, which has a exovitic evolution, and it's heterogeneous. So most probably, I would say it's a clear cell carcinoma.
Right. So you think it's a kidney cancer? It's a renal cancer, right? Obviously, pathology.
Yeah.
Okay.
So I would probably do either partial or radical nephrectomy.
Right. Okay. So which one would be your preferred choice here? That's the patient is too fit person.
Actually, it depends on the patient, on the general health of the patient and the status of the other kidney.
Okay. So patient is very fit, right? Mass in front of you. What would be your inclination if patient asks?
I would say radical nephrectomy for this patient.
Right. That's a very valid choice, right? Dr. Blackmore,
since the other kidney is normal and the
other kidney is normal, rest of the CT scan is fine.
GFR is normal, yeah.
Yeah, that's normal as well. Dr. Blackmore, what would be your choice?
5.3. I think it's quite tempting to suggest doing a partial in that. It looks quite exophytic, so long as you probably like to see a bit more of the kind of slices of that CT, but it is quite tempting to try a partial on that, I think. Obviously, you come down to the same discussion again of whether, in many senses, an open partial is that a superior option to a laparoscopic radical. But partial definitely would be my.
Okay, we wouldn't. That's fine. Partial is fine, and we wouldn't have to worry about lap or open, whatever is feasible. in a center, we would just go for so partial nephrectomy, right? Okay, so Mazhar, what would be your choice here?
I think we need to consider both the options as highlighted by others. What are the nephron sparing is always a better choice. So if it's feasible, whatever modality, I'll go for nephron sparing.
Nephron sparing surgery. And Professor Lizrak, what would be your choice? Okay, Ali, what would be your choice?
So Zishan, quoting the European Association of Urology guidelines, so partial nephrectomy is preferred in T1A and T1B tumor. So this one is by definition a T1B tumor. Yeah. I would definitely counsel the patient for the possible risks entailed with the partial, even though my colleagues claim that, you know, they stated that it's kind of exophytic, but it has a wide base and is definitely in contact with the collecting system. You can see that actually it's less than 7 millimeters from the collecting system. So there's a very high risk of urine leak in this case, and of course bleeding. I couldn't see, well, sorry, I'm seeing actually the coronal. So it's this tumor is going through the interpolar line as well in the coronal image. So definitely the tumor is getting blood supply from the upper, middle, lower part of the kidney. So it has a significant risk of bleeding. And that's the intriguing thing about these kind of tumors. You know, one would think they are easy, but actually once you go in, you will be faced with interesting surprises. So partial, if it's feasible, as long as the patient is well informed about the potential risks, which are not trivial here.
Great, fine. So I think consensus is partial, and this is exactly what I did. 4-centimeter tumor, I don't know, I think they shrink in fixative and become smaller on final pathology. Grade 3, conventional Killier cell. So Yusuf, your guess was right, it's a Killier cell. But as Dr. Thaveni was suspecting, it's going into segmental branch of the renal vein. So it turned out to be a pathologically T3A by definition. There was some necrosis as well, which makes things worse. And on my end, there was a sinus margin positive, at least at one side. There was no issues with bleeding and urine leak. It was an open procedure, so things were controlled. Post-op EGFR remains well, right? So what happened here now? Okay, great. So the slide's gone.
Well, until you get the picture back, Zishan, very well done. Obviously, you have saved his kidney function, and you know, oncologically, your partial was, I would say, it would have been equivalent to a radical nephrectomy anyway.
That's fine.
And studies have shown that positive margins have little relevance with the oncological outcome. Sorry, I'm not going to interfere.
That's fine. I just wanted to ask. Right, fine. So we'll come back to you, Kasal here. So for this margin positive, right? What would be your option? What do you think we should do? Should we observe it or do something else at this point?
Okay. So a positive margin according to the European Association of Urology guidelines does not have significant impact on oncological outcome. So most time you can also observe the patient and see actively and see how it evolves.
Okay, great, fine. Ninad, what would be your choice? Are you going to observe? Right. Okay. So fine. Okay. Ninad is not here. I think Professor Lizrak, how would you manage a positive margin?
Oh,
yes.
Sorry, Zishan, I muted myself. Sorry, beg your pardon.
Okay.
Sorry, do you want me to speak or someone else is doing?
Yes, yeah. Obviously it's a poor pathological status, and then there's a positive margin as well. So what would be your thought at this point? Would you take the whole kidney out or go back and do a bit more of partial?
I don't think a bit more partial for me. I don't think that's going to work. I mean, it is grade 3, you're right. There's a high risk of relapse. So, I mean, either you've got a consent or you end up doing a completion nephrectomy, I think, or you could take a risk and just observe it for a while.
Okay, great, fine. So I think consensus is just observe it for a while, which we did. And this was post 1 year scan, right? So which appears fine. At 2 years scan, right? So Sami, what do you see here? If you want to tell me on the right side scan, I don't know.
So on the right, it seems that the tumor is actually increased recurred and potentially going towards the liver. I don't know if it's going on to the liver bed there,
okay.
But it's definitely, there's some growth going on there. So I likely would need active management at that point.
Great, fine. So, right, and sorry, something is wrong here with my, great, fine. So, and how about here? This is the, I think this is tortuous artery collecting system. This seems to be the renal vein, right? So, Sadiq, do you appreciate anything else on this scan? We have already seen tumor has recurred big time. Okay, fine, great. So basically it's involving the renal vein as well, right? So we had a recurrence, and not just recurrence, it was a segmental branch positive tumor in 2 years, has grown 4 centimeter, gone into the renal vein, right? So straightforward, we did a radical nephrectomy, 45 millimeter tumor, grade 3, PT3A, not just going into vein, but also into the sinus as well, right? Great. So patient is doing fine, 6 months. I think it was in March this year, just at the beginning of COVID. So if I just go back to the consultant panel, Ali, what would be your thoughts? Would you still like, it's best to just start with surveillance these cases?
You mean following your partial nephrectomy?
Yes.
It's a very good question, Zishan. The answer would be the extent of the positive margin. So I've done, I claim that I've done some partials, and I know I know that like I have left really wide surgical margins, and I would normally have very low threshold to go back in. And sometimes I think to myself that I have done a really good job at remove the whole thing. As we all know, renal cell carcinoma grows by compression as opposed to invasion. So when you do your partial nephrectomy, you have a nice pseudocapsule to differentiate the tumor from the surrounding regions. So if you think that you have removed the whole tumor, Zishan, and you didn't see the fat, the clear cell, which is kind of fat cells inside the tumor, then most probably, if you have positive margin, it will be microscopical, and I wouldn't have gone back on it. If, however, you have grossly breached the capsule, then you remember your first case with me, Zisha, when you came to the Belfast Trust, it was actually for a second lap partial for a lady that I knew that I didn't do a good job. And lo and behold, when she came back with positive margin around 3 centimeters from tumor, I took her back in and I removed actually, the tumor bed, and until now she's clear. So I'm throwing the ball at you, Zish. No, if it was a microscopical margin, I wouldn't have done anything apart from observation. If it was a gross, positive, then I would have had a low threshold to take the kidney at an earlier stage.
Great, and I'm just going to pass this ball on to Professor Lizrak, right? Professor Lizrak, are you still with us? Is your mic mute or? Yes, Prof. Prof, what would you have done? It was.
Yes, I am still with you, but I have some problem with the.
Okay.
Yes, what I would have done, I would have done the same thing. I will do active surveillance, and I agree with Ali with this same reasoning. But actually, I think that with experience, the risk to have this limit that is not same is. Very low. Okay. Otherwise, if we are not sure, can we during the partial?
Yes, yeah. Sorry, say again.
Yes, I have a bad connection, problem with the connection. So I am asking about for the resident. Normally, the macroscopic evaluation and experience of the surgeon is mostly sufficient to know that we are in the good plane. But if we are not sure, is there a place for frozen section analysis of the tumor while the patient is
still on the table, right?
Still open, or we are still in the.
Yeah, I don't think the guidelines are clear on fresh frozen sections. Yeah, otherwise the experience of the surgeon and the plane of the resection of the capsules are very important. But the guideline is not clear on fresh frozen section. I don't know if anybody has.
Great. So I think the consensus is we would have just still observed her unless there was positive margins, a huge amount of positive margins. Okay, great, fine. So we will just move on now. So, right, so what is it? So this is a case of 73-year-old male who had previous anterior resection plus 2 cycles of chemo. Patient is disease-free, right? From that point of view, CT scan 2018 sometime, 7.5 centimeter Bosniak fossa, which was being observed. Patient has CKD, EGFR is 29, high blood pressure, otherwise reasonably fit. Performance status, actually it was 0. I don't know why I have written 1 here, right? So fine, okay, Sadiq, why don't you just tell me what do you see here on this picture?
C'est Kassel?
No, Sadiq,
Hello?
Abu Sadiq,
Can you hear me? Yeah, there is a huge tumor in the left kidney involving the lower pole and the mid pole. And it's heterogeneous, so it looks like a malignant tumor of the left kidney.
Fine, great. James, if I come to you, it's a Bosniak force, says about 7.5 centimeter. How much chance of cancer do you think it harbors?
High easy chance, so over 80%, I would say, I think.
Okay, great. So what would be your choice of the treatment now? The patient's history is in front of you. She's
simply looking at the renal mass, you'd say a radical nephrectomy. It's going to be a difficult nephrectomy because he's previously had an anterior resection and need to be cancelled at the fact that his EGFR will take a hit as well. But I think oncologically that would be his best option.
Okay, radical nephrectomy. Okay, great, fine. Sami, what would be your choice?
I think an open radical nephrectomy is probably likely what would happen, unless someone could do a retro approach laparoscopically, but looks like it would be a difficult case even if there wasn't adhesions given the size of the tumor.
Okay, great, fine. Yeah, 7.5 centimeter, fine. Okay, great. And Yusuf, can we have your opinion quickly as well?
Yes, I join my colleague for the radical nephrectomy because the partial will be really difficult in this case.
Fine. So we will have opinion quickly from
yeah.
Mazhar, what would be your choice?
So I think an open radical nephrectomy would be a good choice because intra-abdominal adhesion from previous surgery will make laparoscopic more difficult. Yeah.
Fine. And Dr. Sheikh, from a consultant panel, what would be your opinion?
Yeah, it's a difficult situation, EGFR, so assessment, get nephrologists on board earlier, and open radical. Laparoscopic or minimal invasive will be difficult, challenging position.
Okay, that's great, fine. So, fine. Ali?
Okay, so he had an AP resection before, so I guess that's transperitoneal. So I think there is still, theoretically, you can do still retroperitoneal, open left partial. He's got an EGFR of 29. Assume, depending on the DMSA, of course, but anatomically, they look almost equal. I think if you take that kidney out, he'll be in big trouble. He had 2 courses of chemotherapy. If you take that kidney away, and if he requires further chemotherapy, you are depriving him of chemotherapy. So I'm coming across probably too strong in my opinion. So I would definitely have considered a left open partial nephrectomy, maybe retroperitoneal.
Fine. Okay, fine. So that's why you have trained me, because I did the DMSA as well, which has suggested equal function, and I went ahead and did a partial nephrectomy, right? So partial nephrectomy, August 2018, G3 T1B disease, 7 centimeter, 80% necrosis, PEP type 1. Margin status were unclear, surgically negative, because again, like Professor Lizrak and everyone has said, the surgeons has their own, obviously with experience, know what they have done. And I took tumor bed biopsies as well. I mean, we don't always have a facilitated system on of frozen section, so but I take them because that again provides some information which are all negative. Post-op EGFR 20 to 23, right? And that was, it has dropped a little bit, right? How would you follow that up, right? If I come to you, Sadiq, Abu Sadiq, are you with us? Okay, Kesal, how would you follow that up?
Yeah, so post-operative, these patients with T2, T3 tumors can be followed up 3 to 6 months with imaging, ultrasound, CT scan.
Okay.
And basically on the follow-up, you can do the kidney function test to assess for kidney ongoing GFR to make sure the kidneys are intact.
Fine, great. Is ultrasound good for seeing any recurrence on the residual tumor, residual kidney?
Yeah, so also ultrasound can see a tumor, but it's not as sensitive as a CT scan. But initially, it's advisable to start with an ultrasound. Yeah. And if it warrants further imaging, you can proceed to a CT scan.
Okay, great, fine. So, I mean, MRI scan is good. If facilities are available, and as like already we have spoken that few facilities, they're in one center, not other, but MRI without contrast can give you a good answer as well, right?
Okay.
So,
I think CT should be out with EGFR 17. It won't be compromising further nephrons, isn't it?
yes, yeah, we are looking at him with MRI and a non-contrast CT. And the last follow-up, July, 2 years, no recurrence so far. EGFR is down. That's not because of my partial.
The people that are going to
okay,
interview me next week are doing a seminar.
Okay, do you have his voice down or someone who's not involved in the
Hello? Aslam? Hello, Aslam?
Yes. Hi.
The contrast CT may further compromise the renal function because of the EGFR of 17. So where facilities are available, MRI would be preferred to follow up these patients.
That's great. That's great. Fine. So
yes.
That's the right approach. Brilliant. So
can I add a comment?
Yes, please, Professor Israel.
Yes. This is technical comment for resident. There is a difference between, for partial, between solid tumor and cyst. When there is a solid tumor, of course, we have to do some protection, but it's okay even if we do we open the capsula. But in the cyst, we have to be sure that we have not opened any cyst and any fluid. We have to do protection of the field, like we if we are operating on a hydrated cyst. Okay. This is the technical part.
That's great. That's and thank you very much. And I think on that note, it also reminds me one of the reason why because you have mentioned cyst again reminded me, because it was Bosniak 4 cyst, 80% chance, but and to be, for me, with my little humble experience, they always turn out to be cancer. So, but I still had that 20% benign chance in the mind, and that's why I just said it will be a shame to take out the kidney and drop the EGFR to 9.
Yes.
That's why at all costs I want to do a partial, even if it compromises on any margin status. Because if it turns out to be benign, then that would be a huge shame. Agreeing, Professor Lizrak?
Yes, yes, of course. And you know, for me, it is really possible to do a partial without compromising the margin status.
Yes, yeah.
Yes.
Great. And again on this is patient, the margin status was not positive, it was slightly unclear, like, because you can see the extent. So I think I do need that much of a margin to myself that I could not really clarify that was clear or not, but it was not definitely positive.
And Zishan, it was an extraperitoneal approach you took.
Yeah, I do retroperitoneal anyway, so that just avoids everything. Great, fine.
Thank you.
Marvelous. So case 4, presented in 2013. Presented 2013, 51-year-old male who has neurofibroma of the spine since 2018. Kidney lumps were noted, multiple bilateral 2013, fit and well patient, low BMI, normal EGFR. So if I show you a bit of slices here, you can see this lump here. In here, you can see this lump, this tiny bit. There is a tiny here, and at the upper pole, there is one, and there were a couple others, right? So in total, easily 6-7 lumps together in both kidneys, about 2 to 3 centimeter. Patient is young, right? So fine, James, how would you proceed with this patient? Yeah.
Hi. Have we said we've biopsied any of these? So the bigger ones?
Sorry?
Have we biopsied any of these?
No, this is the first presentation.
Oh, okay.
So how would you approach this?
Well, I want to know a little bit more about the neurofibromatosis, and whether that truly is a diagnosis of neurofibromatosis, or whether there's a chance that this person's got VHL or something else. And then I'd also consider biopsies of these, I think.
Okay, great, fine. So the genetic question, we will come to that because that was all revealed a bit later. So this patient, basically, you think we should biopsy that, right? Sami, what would be your opinion?
I agree, biopsy and neurofibromatosis has difference, but also just making sure you get a radiologist who would look at them, the CT scans a bit more clearly to see if any of them are actually AMLs or not.
They are not AMLs. They're like small renal masses, right?
So biopsy would be the next step, really.
Right. So you both are starting with biopsies. Casal, what would your opinion be?
Yeah, in this case of neurofibromatosis, the risk of VHL is high, so therefore I think we should do a biopsy and do an active surveillance of both masses because surgery would not be the best choice.
That's fine. So you wouldn't proceed with surgery, biopsies, right? Ninad, what would be your opinion? You agreeing with the boys?
Yeah, I think we'll have to agree, isn't it? I mean, you've got to be very careful with so many tumors that you don't be too aggressive.
Great, fine, right. So this is exactly what was done. I was not a consultant at that point there. So 2015, biopsy was done. Fibromuscular fibrofatty tissue, it was a good sampling, right? So we are back to where we were, right? So if I may ask again, Yusuf, what would be your plan now?
Sorry. Yes, I joined my colleagues for the biopsy and active surveillance.
Fine. Okay. So biopsy has not shown any cancer. Sadiq, what are you going to do? Biopsy has not shown any cancer.
Yeah, biopsy has not shown any cancer.
No.
I want to. Hello, can you hear me?
Yeah, we can hear you. Go ahead.
Hello.
Yes, we can hear you.
Yes, there's no cancer. There's no cancer in both kidneys.
No.
I will follow up the patient closely by imaging.
Okay.
And if there is increase in size, there may be need for further evaluation, a repeat biopsy. This is a young patient who has bilateral renal tumors and likely familial and is at risk of having more problems later in future. So I'm not in a hurry to go for surgical therapy in this patient. Fantastic. So I want to follow up more closely.
That's fine. I really like that. Ali, can you agree with the boys, or do you have different opinion?
So I probably do. And the other thing that might be worthwhile considering is referring the biopsy itself to super centralized center, like super regional, just for another looking at it, because it's just interesting. This is syndromic, could be part of VHL, could be part of Birt-Hogg-Dubé syndrome, could be part of tuberous sclerosis complex. But I think my first inclination would be just to follow up because there's no malignant cells.
Great, fantastic. So I'll keep that in mind about super specialist center, and I'll come to that. Great, fine. So what we did was that we did observe, right? Scan continue. We are on to 2017, and I think it was at this point I got in with this case. You can see these are just one slice. It seems clearly bigger here, and you can see these pictures. These are other slices, right? Fine. So everything is quite big now. All right. Biopsy at this point, clearly the answer would be what would you do now, Yusuf? Bigger, both masses.
Can I ask what's the EGFR now?
Everything is fine. Patient is running marathons. His EGFR is normal.
Yeah, I would say to continue surveillance.
But no, masses are here, man. They are like this mass here in the full slice is about 7 centimeter. Two together, this is 3-4 centimeter, right? What would you do? Biopsy or just go ahead?
I would say to do partial nephrectomy for the biggest one.
Okay, great, fine. Right, and Sami, what would be your choice?
I would probably try to do partial nephrectomy on the larger lesions. Definitely the one on the right side first.
Fine.
And then.
Fine, great. So what we did was that we again biopsied it first, right? Because of the tricky nature of the case. And it suggests a renal cell epithelial carcinoma, unclassified, right? And in the meantime, his son was diagnosed with, coming back to Dr. Blackmore's question, SMARC B1 gene deletion, right? You guys can read about it later on, which is associated with aggressive renal cancers as well as rhabdoid differentiation, which is again a pathological dilemma, right? So this is the current picture we have, right? So Sami, you are mentioning about partial nephrectomy. Great.
Yes.
Fine, great. James, what are your thoughts now?
I'd agree that to go for partial nephrectomy, the one thing in my head is if you know his son's got an aggressive gene disorder and you are, actually present at the time doing bilateral partials, should you also take some of the smaller lesions that you can get as well at the same time?
Okay, great, fine. So, right, and so basically stage partial, right? Professor Liesreich, what are your thoughts on that?
Yes, I agree, of course, with the stage, with the partial nephrectomy. And if we can take also most of the lesions that we see, especially if we have or the other small lesions with the radio frequency, if it is available. Otherwise, I will do enucleations of the small tumors.
Small tumors, great, fine. So we have a consensus here, and I'm sure those I have not asked would have the same opinion. So exactly as I think Dr. Thamini was mentioning, I had opinion from one of our very, very respected senior figures of British urology in Oxford, right? Mr. Cranston, who had pretty much same exactly what Professor Liesreich has said, to remove bigger lesion. And I think James, and what James says, and remove as many lesions as possible, followed by any ablative treatments if possible. So we did a stage partial, right-sided, in April, 3 tumors, 2 were en bloc. The total lump of that was about 7 centimeter. Margins were clear. The left-sided, when I did, we removed 4 tumors varying from 12 to 25 millimeter, unclassified, more aggressive than before. And there was some area of surgical margin positivity, right? So he's about 52 now, right? So if we come back to you, right? So Yusuf, how are you going to follow up this patient?
I would do a CT scan every 6 months for the follow-up.
That's great to start with. Anything else you can do, because he's young and he's probably going to need lifelong follow-up? Fine. So we can do MRI as well, right? Great. So
yeah,
just to reduce. So this was the last MRI where this was the biggest lesion. As you can see, a lot of lesions are just cleared. This is not a lesion. This is some muscle or something. So this is about 2.23 centimeter lesion. He's awaiting ablation, but then COVID started, so he's still on hold. Okay, great, fine. So, right, so we will move on to the next case now. So any comment, Ali or Ninad, any of my senior colleagues?
No, I think I think the main issue is, as you said, in these genetic syndromes, MRI scan should be the preferred. And I mean, as you rightly said that, and I think that's just something to be borne in mind. Obviously, facilities permitting, but.
Okay, fine. And in terms of how we approach this case, anything different?
Yeah, no, yeah. I mean, I think so. Yeah, I think you have to refer it to a super-regional center generally, because they'll keep having bits of the kidney removed for a long time, and eventually, you must, I think, get their opinion as well. So, like you rightly did.
Fine, that's great. Yeah, I mean, it was just opinion sought for the report. Operation was done here in our hospital.
Yeah, no, that's very good actually what you did. But I mean, and that's creditable. But yeah, I think a lot of people would actually send it to Oxford for that sort of thing.
Yeah. I mean, Professor Cranston, for some reason, he still replies to my and Ali's emails, despite that he's retired. So that's.
I've sent a patient like this to Oxford, and I think I did the right thing. But it's well done.
I think Zishan did a good job. Yeah.
No, I wasn't looking for appreciation.
No, you don't need to.
Right. Great. Fine. So we'll move on to the next case. So this is a patient. Do we have Dr. McMiniman with us? Because I'm not letting people like Dr. Rona McMiniman. Are you with us already? Consultant oncologist.
Hi there, can you hear me?
Yes, yeah. Thank you very much, Dr. McMiniman. We were just coming to some metastatic cases, so.
Okay, I've just got about 10 minutes, Zishan, so I hope that's okay.
Okay, all right. Okay, that's fine, good. Right, so case 5, June 2018, 81-year-old male, varicocele, he presented with fit performance status of 0. So these were his blood parameters, which was all fine, neutrophils, platelets. Left-sided renal mass, 8 centimeter, reported pyrotic nose, 3 centimeters, right? So this was the scan, which has suggested this mass, and there's some lymph node bulk here, right? No other metastatic disease. So Kesal, why don't you just start? What would be your options here? How would you approach this?
Yeah, this patient is a T2 N positive tumor N1. So therefore, according to the guidelines, the patient should receive a radical nephrectomy and a lymph node dissection according to the EAU guidelines. Yeah.
Mm-hmm. Okay, great. So you would do radical nephrectomy, right? Great, fine. Dr. McMenamin, if I could have your opinion here with a little bit of evidence regarding what would be your as oncologist opinion?
Well, I think he's an elderly man. He's 81, so I think we have to take that into consideration. And also, if he's got paraortic nodes, is this going to be something that we can operate on, and should we operate on? And perhaps there would be options for non-surgical treatment here. I do see he's fit.
Mm-hmm. Fine, great. So yeah, I think when we had the discussion, the opinion was mixed about taking the kidney out or going down the systemic route. Eventually, patient opted for systemic route. So went on to one of my other oncology colleagues. A biopsy was done, which had suggested clear cell RCC, and patient was planned for systemic treatment. But when the CT scan was done, there was significant reduction. Well, it was reduced by about 50% without systemic treatment, lymph node mass, and some reduction in the size of the lesion as well. I think it was just the thought of systemic treatment. Great. So
that's how good it is.
Sorry?
That's how good systemic treatment is, Zishan.
Exactly. Just the thought of it. And
miracle.
Yes. So, Sami, what would be your plans now? How would you proceed?
Well, depending. Sorry.
He's all prepared and ready for systemic treatment.
Yeah, I mean, there is a role for sort of cytoreductive nephrectomy in these kind of cases, but it obviously depends on his fitness and motivation, and also you'd have to counsel the patient regarding.
3 times a week. He goes to gyms 3 times a week.
Yeah, so cytoreductive nephrectomy would be a reasonable option for this chap.
Okay, great, fine. Mazhar, what would be your thoughts?
I would agree. I need to counsel the patient. We need to tell both the option, and if it's suitable, well counseled, I'll go for cytoreductive.
Right. Okay. And Dr. McMenamin, what would be your thoughts now?
Well, I think it's interesting. He's had a reduction in the size of the lesion and in the size of the nodes. I think you could argue you repeat the scan in another few months and not do anything at the moment in case the reduction is ongoing.
Okay. And the lesion might completely disappear.
You never know.
We have a tissue diagnosis of cancer, isn't it?
Yes, clear cell.
Yeah, I think I missed it. I missed it. The biopsy had confirmed. Fine.
On the phone. Thanks.
Fine, great. So we had seen the patient, and as I think the consensus has been, we went ahead and removed the kidney this time, right? So it turned out that, as expected, it was pathologically G4 with rhabdoid differentiation, 4.8 centimeter, 30% necrosis, clear cell RCC, right? Dr. McMenamin, can you please just enlighten us, like how do you choose your patients when you advise for cytoreductive nephrectomies? What group in terms of risk?
I'm sure you're aware of the studies done, the surgical studies done that, you know, I think were obviously needing to be done because the role was unclear. I think the role for upfront cytoreductive nephrectomy, I think what the studies have essentially shown is that you don't need to do it up front. You can give patients a spell on systemic treatment first. They're not going to be disadvantaged if you don't take the kidney out first. The other thing that's obviously very important is to do the Heng score and look at their prognostic factors, and certainly only very selected patients with intermediate risk disease and patients with poor prognosis disease should not get cytoreductive nephrectomy, because Carmina and Surtime showed that they did badly.
Great, fine. So from this, just by a quick look at it, everything is normal.
Yeah.
I did look at the IMDC criteria this afternoon, and his performance is 0. So would he fall into low risk category?
Yeah, he probably would. As I say, he is 81, so I think that still needs to be taken into consideration. So
okay, great, fine, right. And in terms of organ involvement, like if let's say there's a liver metastasis found, does that automatically rule out cytoreductive for you?
For me, it would, yes. I don't think that's the right thing to do. And sometimes we've all seen it happen. Someone has surgery, and then in the recovery period before you can start any systemic treatment, the metastatic disease starts to progress.
Right, okay.
And that's always a worry if you've got poor prognosis sites of disease like liver or multiple bone mets.
Fine, liver and bone mass, absolutely, great, fine. Right, so I think the message is if this lymph nodes and low volume lung metastatic disease, patient is fit, then cytoreductive was
certainly could be considered, yeah.
Okay, that's the message for residents to remember to take home. Great, fine. So this was it, and then patient is fine, CT 2 years, no recurrence, lymph nodes have further regressed. We never know whether they were actually cancer or whether they were just reactionary, but however, they are gone. Any adjuvant treatment in such cases with low volume metastatic disease at the time of cytoreductive?
There's no role for adjuvant treatment as such in this setting. If it's truly adjuvant, then it's something that clinical trials, as you know, are trying to address. Currently, we've got the Rampart trial looking at the role of adjuvant immune-oncology drugs in this setting. All the true adjuvant trials like SOURCE were all negative, looking at TKIs in that setting. As you say, we don't really know if this man, in fact, therefore had metastatic lymph nodes when they disappeared. So I think whether or not this would have been truly adjuvant, I think is difficult to tell.
Great, fantastic, right. Grigoris, you had raised your hand a few minutes back, and I'm really sorry I missed it. Did you want to say something, please?
No, that's fine, thanks. It was for the first case, but that's okay. I think I wholeheartedly agree with Rona about, I mean, as time goes by, I'm increasingly in favor of applying active surveillance or watchful waiting rules for all these patients. I do think, judging from a quick look at these scans, that lymph node dissection would not be that difficult to be performed in this instance, even you know, with minimal invasive surgery. But yes, that's more or less the case. Yes.
Fantastic. If it does not add morbidity, then yeah, why not? Yeah. Rona, if I may request just to stay for this case, if it is possible.
You know, I'm very sorry, Zishan, but as I said to you earlier, I'm going to have to go. I've got a taxi to take me to the garage to pick up my car. So I'm very sorry I can't stay for the final case. I do apologize.
Okay, all right, that's fine then. Thank you very much. Thanks a lot.
Thank you.
Fine. So 56-year-old male, cardiac MRI picked up again 2013. The patient was under me at that point. Cardiac MRI had picked up an 8-centimeter left-sided renal mass. Past history, congestive heart failure 2012, but patient is stable. Performance status of 0 and eGFR greater than 60, right? So this is the scan in front of you, right? So yes, Sadiq, how would you proceed? What would be your option for this patient? Okay, Sadiq, can you hear me?
Yeah, I can hear you. This is 8-centimeter left renal mass, and it's likely a malignant renal tumor. Though the performance status of this patient is good, but he has got congestive cardiac failure. So I'll first of all do a metastatic workup for this patient because of the size of the.
What would be a surgical option for this cancer?
Surgical option for this patient, relatively young, 56 years old. I want to cancel the patient for possibility of radical nephrectomy.
Okay, great. Is there anybody who would consider a partial on this patient? No? Great, fine. So
yes, excuse me. Let's talk just about the technical possibilities.
Yeah, please.
Yes, if we see I cannot judge but by only this CT scan, but I have to see the other images. But if we see the guidelines, European guidelines, so radical nephrectomy is the recommendation, laparoscopic radical nephrectomy for this for T2, if partial nephrectomy is not possible. So just seeing this CT scan, I think it is possible to do partial nephrectomy in this case. Of course, we have to see if there is a lot of parenchyma that will remain in the other part of the CT scan.
Fine, great. If yes, yeah, it's not all the views, right? Ali, Dr. Triveni, what would be your opinion? Right, okay. Ninad?
I think I don't have that much experience, so I wouldn't be brave enough for a partial. I think I would do a radical.
Yeah, so this patient has radical nephrectomy. I mean, he wasn't under me, but to be honest, even if I was, I would have done a radical nephrectomy on him, right? And that has suggested grade 2 clear cell RCC, but perirenal fat involvement, margins were clear, right? Great. So low grade, but perirenal fat involvement. Dr. Blackmore, how would you follow this patient up?
CT, probably three months, 6 months.
That's great, fine. So he had a CT scan done. This was 2016, 3 years later. You can see I've marked it, 2 renal bad recurrences, less than 1 centimeter. Fit EGFR was low but reasonable, right? And radiologists thought these were actually, in hindsight, present 2015 as well. So they've slightly grown, right? So James, what would be your approach now?
You could either watch and do nothing, or probably more tempting is to try and remove these, I think. Or the other option would be some form of systemic therapy, but I think probably trying to remove them.
Right, so you are going for excision, right? So Kesal, what would be your thoughts?
Yeah, so there are options. You can do a percutaneous biopsy of the tumor bed, or you can just follow up on imaging and see. There's an option, or one option you can do excise the tumor bed.
Fine, okay, great.
Can I make comment, Zishu?
Yes, please, yeah.
I think since they are less than 1 centimeter, it would be very, very difficult to get them even with a CT guided biopsy.
Yes.
Even with very experienced radiologists. The other thing is that you could offer them a little bit of, I mean, they would be quite convincing, obviously, of these CT scans. This CT scan, was it the first one post-operatively?
No, this was year 3, third year.
Year 3, that's fine. Okay, yes, fine. So that would be quite convincing. I mean, I do appreciate that you would need some tissue diagnosis if you are to proceed with, you know, maybe offering them some systemic treatment. But it would be percutaneously, it would be quite challenging, I think. If anything, that would be, you know, with another way to try to get some tissue diagnosis. But again, it will be quite challenging if they're that small.
Yeah, I mean,
I think it may worth it to do a bit of maybe, you know, monitoring for this.
Yeah, fine. Biopsy is not really required because our radiologist is convinced, right? So you are going for monitoring as well. Mazhar, what would be your thought?
I will go for systemic treatment and then.
Okay. So these are the only 2 recurrences, no other metastasis anywhere. Right, great. So you would do systemic, we have 2 for 1 excision, 2 for observation. Great. Professor Lizrak, what are your thoughts?
Me too, I am for the monitoring because the excision will be very difficult. There are 1 centimeter lesions, and it will be really difficult to find them during the procedure. And for the systemic treatment, since they are the only lesions, we can monitor them. And but I would add a comment. Many people will think that they will do radical nephrectomy to avoid recurrence, just to show them that in our experience, we have more recurrence in the renal bed after radical than after partial nephrectomy.
Right. Okay.
Of course, there are large tumors, of course.
Yeah. Yes. Yeah. I think this is a common observation.
Yes.
Fine. So we at that time it was decided to observe, which I think is the consensus here as well. And even if I was present, I would have agreed with my colleagues in 2016, right? So scans continued, right? And by 2018, this lesion is now here, and this lesion is now here on the left. They are both about 2.2, 2.3 centimeter. A tiny 7 millimeter new lesion has appeared, right? But during these 2 years, no other metastatic disease, right? So if we go back again, right, Yusuf, what would be your option now?
I would say systemic treatment.
Systemic treatment, okay, great. That's a valid option, right?
Yeah.
What are your thoughts now?
Sorry, is that me or?
Yeah, Sami, you can go ahead. What are your thoughts?
Well, I was going to say is earlier there is a possibility of maybe RFA, but radio frequency ablation. But I think now that there's 3 of them, that might be a bit difficult.
Okay, great, fine. And fine. And if we come back again, Ninad, what are your thoughts now? Yeah, go for it.
Sorry, Zishan, I missed that for a second. Sorry.
So what are your thoughts now? The lesion has increased to about 2.2, 2.3, and there's a tiny 7 millimeter lesion appearing as well, new.
So is it biopsyable now? Is it? Sorry.
We haven't, because we are quite sure in MDT that it is a metastatic. So yeah.
Okay, and his performance score is still okay, and overall his general condition is he still good?
Yes, he's slightly high BMI. Otherwise, he's good. Quite motivated patient. Yeah.
Okay, I mean, I'd obviously I'd defer to the oncologist and see what they think about systems.
Now, Grigoris, what would you just suggest on behalf of your oncology colleague?
Well, I would refer to the oncology team, and I would be more in favor of maybe considering starting systemic treatment. Again, RFA, I'm not sure because of the size how easy it would be, and the proximity of the bowel is a bit of a concern.
Fine, great. So can I just tell how I approached it?
Yes.
I have a bit of consensus. So first of all, I just took some opinion from some of my pan Glasgow colleagues where I was more in communication during those days. So they had not suggested systemic as well, which I was quite not in favor of either, because my reason was that these are lesions which have the only lesions appeared over 5 years since diagnosis in 2015 into 2018. They have grown, but nothing new has appeared. So systemic, I just felt could be an overkill, right? And then so their opinion was the same, either ablation or surgery, right? Which really kind of reassured me. So for ablation, I discussed with our radiologist. So again, what Mr. Grigoris has mentioned, this bowel is very adherent to that, so that won't be possible. So we went ahead and excised these 2 lesions. This lesion was almost impossible to find, right? But our radiologist has already said that if this lesion grows before surgery, this could be easily ablated target-wise, right? So that was my reason that even if I leave that, we have got a minimally invasive approach, right? So are people agreeing with me for doing that? Any comments?
Yeah, I mean,
yes.
Yes.
Okay, great.
Yeah,
Yeah, great, fine. So we did do that. Observation, systemic surgery, 2 years post-surgery, small lesion is stable, fine. So he's fine. So that, I mean, I think that was a case where systemic was an option as well. But we went for surgery. Luckily, he did very well, home 4 days. So no major issues. Great, fine. So again, we would have, we don't have our oncology here. So case 7, August 2020, it's not long ago, 55-year-old female presented with left hemianus hemianopia and headaches to the ophthalmology. MRI had 2.8 centimeter right occipital lobe lesion and CT scan about 5 centimeter renal mass. Patient has a high BMI, previous low-grade endometrial cancer, surgery in 2017 done for that, type 2 diabetes, and these are other markers, right? So this is a lesion here. Can we see on the occipital lobe about 3 centimeter? And this is the renal lesion. Okay, so you have these 2 scans in your mind. And if I ask you again, Sadiq, how would you approach this patient now? What do you think is happening
at this point?
Sorry.
At this point, I want to introduce systemic therapy for this patient.
For what?
For the new lesion.
Okay, all right, great, fine. So what do you think this is, this brain lesion? What do you think this is?
Well, this could be metastasis.
Yeah, this could be metastasis. And if I come back to this, this is a 4.5 centimeter lesion. Kesal, what do you think now that lesion could be? It could be metastasis.
Yeah, it's possible. It could be metastasis. So probably we can establish a biopsy from the primary lesion. It could make people considering systemic therapy.
Okay, great, fine. And fine, Sami, how would you approach that?
Sorry, sorry about that. What I was saying is really you could observe, but I think if you're very convinced that this is metastasis, then systemic treatment would be the right way forward.
Right. So, Professor Lisbon, what would be your thought about approaching this case? It's a only 4.5 centimeter lesion, and there is a brain lesion at the same time.
The question was for me?
Yes.
Yes. So we should be, I think we should do a biopsy of the renal lesion to be sure, since there is, in the history, there is a uterus cancer in 2017.
Okay. Great.
Yes.
Okay.
Before we can decide which systemic therapy we will do, if it is the metastasis.
Fine, great. Right. And Mazhar, what are your thoughts in relation to this lesion and the kidney lesion?
So the kidney lesion could be the metastatic deposit, considering its like size. So we need a tissue diagnosis before embarking any further treatment.
Yeah. Okay. Great. Fine. So, I mean, our opinion was that yes, it is likely a metastatic disease, but we could not really rule out for sure whether this is not a primary brain lesion as well, considering that the kidney lesion is only 4.5 centimeter. I mean, metastasis can occur, but again, that made us slightly concerned about doing a renal biopsy and starting on systemic treatment, and the brain lesion turns out to be not metastasis. So on that thought process, what would be your choice now, Kesal, if I come back to you?
Yes, it will be to proceed for. Hello?
Hello, yeah.
To be to proceed for a biopsy, confirm that it's the metastasis. If it is, then systemic therapy will do.
Okay, great, fine. So
I'll just jump in and say, I mean, this is, if you biopsy the brain lesion and that's a renal met as a single metastatic disease, is there an argument to remove that single met and then go chasing after the kidney leak with either a partial or a radical nephrectomy?
Yeah, that.
We talk to the neurosurgeons.
Yes, yeah. So basically, neurosurgeons excised this lesion on 9th of September because this was a solitary, and even if it was a metastatic lesion, the opinion was that excision is a valid option, even if it's a metastasis, right? Single solitary brain lesion, metastastectomy is the option, right? It's just a shame we don't have an oncologist, and systemic treatment does not have a good response on the brain metastasis, right? This is another piece of information. So it was excised on 9th of September with confirmed clear cell RCC, right? And then on 10th of October, on 9th of October, we have removed her kidney. I think pathology is still awaited, right? And so at this point, brain MRI has not shown any residual disease, kidney is out, right? Any further treatment will be decided after the pathology is discussed, right?
I have a question.
Yeah. Yes.
Hello. So suppose that even in the case where the brain metastasis would be like sensitive to systemic therapy, do we still have room for the nephrectomy kind of removing the primary tumor?
Yes, yeah. It's a, so Mohammed, I don't know if you're asking, it's a solitary. Okay, you mean even if systemic treatment was good for brain metastasis? Yes, even then it's a solitary metastasis can be removed. Patient.
Yes, yes, that's what I was.
Yes, yeah. If it's a lung solitary metastasis, it is offered in certain center to remove the kidney as well as the solitary lung mat. And same goes for brain, where especially systemic treatment is not so good. But I get your point. If it was good, then yes, even then metastatectomy of brain lesion and then removing kidney is a valid combination. Yeah. Any other comments? Anyone has any knowledge or experience of this? Grigoris, you must be seeing a lot of aggressive cases. Okay, great. So the next further management plan, any other suggestions? Sami, how would you manage? Her brain lesion is out, right? The kidney is out, right? So how would you follow this up? Any further treatment?
I mean, I think you would just keep a close eye before any systemic treatment, especially if it's the brain's not as sensitive. Yeah. So be early imaging, just to see if there's any change, and then you could start systemic treatment. But I'll be honest, I'm not sure what the role would be in this kind of case.
Yes, yeah, I mean,
yes. Can you consider a radiotherapy, like conventional radiotherapy to the brain lesion?
Yes, this is. I was gonna say whole brain radiotherapy is an option. I honestly am not really qualified to make a comment whether it is best, but this is something which we will discuss for her, right? Whether we should do a whole brain radiotherapy now at this stage, even before anything develops, in case if she has any micromats. But the other option, which is very valid, Samia said, we could just observe as well, and she will need very close intervals CT scans, and depending on where the lesion develops, she will need systemic treatment or could be whole brain radiotherapy. Okay, great. So how are we doing with time? I mean, are we okay to do another case, or shall we just how is everybody with time? We can do another case.
I need to go, Zishan, but thanks very much.
That's great.
Keep going if you have the rest of you.
Fine. Okay, great.
I think, Zishan, we can conclude.
Yeah, that's great. Fine. So
yeah,
marvelous. Right, Sonia, on to you. What did you think?
Zishan, you can conclude.
Okay. Yeah.
Yeah.
So residents, I'll just ask, what are your thoughts? How did you find it?
Resident.
Somebody has to answer, man.
You can unmute and speak. The resident. It's your session. How you find the session?
Kesal, can you just give some input? Or Sadiq, can you give some input?
Yeah, it was. Hello, it was quite interesting. Just that management of renal tumors depends on not just the patient and the tumor factors. Also depends on the available resources. What do you have in managing these patients? So that for us in Nigeria, it means that we have to resort to doing more of radical nephrectomies and cytoreductive nephrectomies. Okay, it's quite difficult to manage small renal masses in the sense that these patients follow-up is a problem because you will not offer active surveillance or ablative therapies for a patient whom is likely going to be lost to follow-up. So here we are, we have a mass that is T2 mass. We are more comfortable if there is good renal function. Contralateral kidney is fine. No comorbidities that will affect the renal function in future. And patient is in the middle age. We can comfortably do a radical nephrectomy so as to ensure that oncological clearance is on topmost priority to us. Because if we have recurrence, we may have difficulties in managing this patient, and that we wouldn't want to have. So it's variation in management of renal cancer, despite the guidelines which we know in management of these patients.
Okay, I think it's a very, very valid point, because with recurrences, obviously follow-up is an issue. You don't want to lose your patient. That's probably that patient gets lost to follow-up and then developing recurrences. You would rather have good cancer clearance in the first sitting. Okay, great. And how about from an educational point of view? I mean, was this a useful session?
Very useful.
Yeah, Sami, you carry on, please. Yeah.
Sorry, no, I was just saying it's very useful in good cases. I think challenging in really for everyone, and interesting how they were managed. Especially, I think the last one was definitely quite an interesting case.
Yeah, she's still kind of ongoing in the process, right? And fine. And how about you guys, Yusuf and Kesal? I mean, shall we do more sessions like that?
Yeah,
Yes.
I think it was really interesting, like brainstorming about the renal cancer cases. It was really interesting to see your management and how the outcome was. So yeah, I'm looking forward to more of these sessions. It's really educative.
Okay, that's great. That's great. Fine, certainly we will.
Yeah, I think it's a very great session because it's interactive and it's boost the retention of knowledge, and it helps also better manage the patients. So I think the multidisciplinary session is very, very good for our own practice.
That's great. Fine, fantastic. So shall we do another on renal, or shall we do something else like bladder cancer, superficial? Professor Niang, what are your thoughts then?
I think we have to move and do another cancer. We will think about bladder cancer next session in one month.
Okay, that's great. Fantastic. Marvelous. Brilliant. So that's it, everyone. Thank you very much for being here. I think it was a good attendance, 60, 62. So that's a good attendance.
Yeah.
So it's all, sorry. Yes.
Thank you. And thank all the panelists. Thank you.
Thank you.
I think I will do it every month, inshallah.
Thank
you. Okay then. Take care, everyone.
Thank you, everyone.
Bye.
Yes. Bye. It was very interesting.
Bye. Thank you, sir.
Yes.
Thank you, Lizrak.
Yes, thank you.
Thank you. Bye.
In Africa, Professor Lizrak.
Yes, thank you. Thank you.
Bye.